So, how did the surfactant impact in our neonatal management? So, in 1950s, in the books I read, they said like for the premature baby, the delivery premature baby, they just give oxygen. That's it. They don't have any ventilators, just oxygen. Survive, they survive. In 60s, they started to do the mechanical ventilation, and in 80s they started to use the surfactant first, and in 90s it was approved. You can see the neonatal death frequency decrease as we progress in the time. So, what are the indications and contraindications? We can use surfactant for prophylaxis or for rescue. For prophylaxis, theoretically, like any baby who's less than 34 weeks has a surfactant deficiency, as I showed in the picture before. And depending on the clinical situation, we might choose to give prophylaxis. And rescue therapy, we use it for definitely for HMD, that's hyaline membrane disease, meconium aspiration in some instances, and maternal chorio where we suspect cytokine injury to the lungs, and pulmonary hemorrhage, and diaphragmatic hernia, and infant of diabetic mother. Infants of diabetic mothers, even though like they're near term, they still have the surfactant deficiency as a part of this disease process. And the contraindications would be the term infants with no complications, obviously, because they have the capacity to produce and recycle surfactant, and pneumothorax and lethal congenital conditions. So we have both natural and synthetic types of surfactant. For natural, we have Surfactant as a bovine, and Infosurf from calf, and Curosurf is a porcine. And synthetic, we have Exosurf and Surfactant. I don't want to go into the details because we don't use them. Okay, surfactant of choice, like it depends on the center to center, and these are the differences between Curosurf and the Surfactant. And for Curosurf, the dose required is small. If you look at it, it's 2.5 ml per kilo for Curosurf, and it's almost double the amount for Surfactant. And the repeat dose for Curosurf is 12 hours, and the repeat dose is 6 hours for Surfactant. And it's still 4 ml per kilo, but for Curosurf it's 1.25 ml per kilo. And Curosurf comes in 1.5 ml vials and 3 ml vials. So that's the Curosurf, and these directions to use I copied from their website. Should be inspected visually for discoloration prior to administration, because there's possibility of contamination because it's a biological product. And the color of Curosurf is white to creamy white, and it should be stored in the refrigerator 2 to 8 degrees centigrade. And before use, the vial should be slowly warmed to room temperature and gently turned upside down. It should never be shaken because air bubbles in the Curosurf doesn't distribute well in alveoli. So we should tie it very gently without shaking. And unopened, used or unused vials of Curosurf that have warmed to room temperature can be returned to refrigerator storage within 24 hours for future use. And do not warm to room temperature and return to refrigerated storage more than once. So how to administer the surfactant? So obviously we have to intubate the kid, and it's very critical to determine the position of the tube. The tube cannot be too deep or cannot be out. It should be between clavicles to carina if you have a chance to look at the X-ray. Otherwise, auscultation is the best method to determine the position. You have to look at the first we can do the CO2 detector, use the CO2 detector, and by auscultating equal breath sounds and equal chest rise, and securing the tube is also very important. And we oxygenate the baby well, and we place the baby on one side using, and it's a sterile technique because this solution goes into the lungs, and any kind of contamination will lead to the pneumonia. And depending on the ET tube size, we choose the catheter size, and we give half the amount to one lung and half in 2 aliquots. Whereas in Surfactant, they do it in 4 aliquots. So we can bag the surfactant, or we can use the ventilator to deliver the Curosurf. And if we are using the ventilator, we should go up on the ventilator settings. Like if I'm using on the PIP, I usually go up by 2 down the baseline, and I go up by 1 on the P, and I increase the I time to 0.4, 0.45, and I increase the FiO2, and after administering the surfactant, we should come down on the settings to the basic. So when to administer? Like for prophylaxis, within 15 minutes of delivery, but we may not be there as a paramedic team, but as soon as possible is a good option. And for rescue therapy, we have to diagnose the condition and administer if needed, preferably ASAP. So I can show you how to draw the Curosurf, and we use do you want me to show?
Actually, if you just stay there and just talk through it, we want to do the demo as a secondary because I'm going to get close for that.
So we determine the volume based on the weight of the baby. As I said, like for first administration, we use 2.5 ml per kilo, and draw the amount a little bit more into the syringe because we need some surfactant to prime the tube, whatever we are using, and we leave the amount which we calculated based on the weight in the syringe, and discard the excess Curosurf. And we match the numbers on the catheter we use to insert through the ET tube, and the numbers on the ET tube, and administer half to one lung, half of them on the one lung, and half to the other lung. So